G'day guys, Jared Powell here, back with another installment of On the Shoulders of Giants. Today, we've got a really special treat. I've just had a fascinating and insightful conversation with Jeremy Lewis, PhD, who is a powerhouse researcher and clinician out of London in the United Kingdom. Jeremy has hundreds of publications to his name. He really needs no introduction. Specifically in this conversation, we talk all things frozen shoulder. We discuss injection therapy for frozen shoulder. Does it have a place and what type of injection? We mentioned briefly manual therapy in frozen shoulder and how it may or may not work. Can we stretch a capsule with our bare hands? Do we have the strength to be able to do it? And we mentioned some pertinent research in and around frozen shoulder as well, culminating in discussing the FROST trial, which has only recently come out in the Lancet journal to critical acclaim. This is a must listen for all you who see shoulders and specifically frozen shoulders in your clinic. Without any further ado, I'll hand over to Jeremy Lewis, and I really hope you enjoy this conversation. I'll see you next time. Cheers guys, bye. Okay, we are live with Jeremy Lewis. Jeremy, welcome.
Hey, how are you? Nice to meet you again. Nice to spend some time with you.
That's good. So we've known each other for a little bit. We've been collaborating, writing together. I'm lucky to have you as one of my PhD supervisors. We've never really discussed frozen shoulder in depth, although we have written something together. And I'm really interested to get your thoughts on it. You're an industry leader. Yeah, you've published extensively in the area of frozen shoulder, rotator cuff related shoulder pain, subacromial impingement, et cetera, et cetera. You've got, I think I saw on your ResearchGate profile, you've got over 100 publications to your name. So I'm in awe of your productivity. How do you do it?
That's very kind of you. I'd like to say it's a few more now, but I haven't been on ResearchGate for a while. But
there you go.
Yeah, but it's not the quantity; it's the quality.
Absolutely. And I'll say this, and you've been a huge influence on me personally in my career. I read your paper, the subacromial impingement. Is it an illusion? Or I can't remember the exact title, nearly 10 years ago. And it made me question everything in physiotherapy, because that subacromial impingement for me was a non-negotiable, easy diagnosis, easy treatment. Centralize the humeral head and you're on your way. But you ruined that for me, and here we are nearly a decade later and we're still trying to piece it together. So thanks for that.
I'm quite unsure. Am I supposed to apologize now or celebrate?
Both.
Okay, fine. Yeah, no, that was an interesting time actually. I remember I was very nervous I was really excited about writing it, and when it came out I got a little bit of, are you sure you know what you're talking about? And I then started getting a lot of flack from physios and from surgeons, and it wasn't comforting, I don't know if that's the right word, but it was interesting to see over the period of time since that was published, the number of studies that really do suggest that the acromion isn't impinging. Like discs don't slip, the acromions don't impinge, and that would be a fantastic chorus to a song that maybe we could write at the end of this.
I can't help you. I'm not going to sing, Jeremy, to save everyone, but I do like it. It does have a ring to it. Or even if acromions do impinge, they impinge in everybody or most of society anyway. So
they touch them. They don't impinge, because impinge is negative, and I would say they touch, and touch is a good thing. So I think they touch.
Good, I agree, and so that was a really interesting time in my life as well. So thank you for that, and I can speak for a lot of other people as well. And we really value the work that you do. So keep it up.
Thank you.
Okay, enough of the compliments.
A lot of what I'm doing is the devil's work for a lot of people, but yeah, thank you. That's nice to start this. It's morning here in London, and it's nice to start the day with a nice conversation. Thank you.
Well, the civilities end now, Jeremy. We're going to get into the hard stuff. Well, firstly, actually,
my broadband looks like it's about to
cutting out. Well, firstly, can you just tell us a bit about you and your history, Jeremy? So I know you're a Kiwi, trained in Australia, I believe, and you've made your home in London now for several years or decades. So
Several
what's
decades now.
in a few minutes? Sort of what's been your story?
Well, just as the wheel was being invented, I was born in New Zealand. I roamed the plains of New Zealand, fighting off brontosauri. As we were talking about before this, I did, my junior school in New Zealand. I had an absolutely privileged life in New Zealand, living by the beach and driving tractors at, I think, age 9 by myself, and taking boats out and net
Where
fishing.
were you? Down south, up north?
Just to the west, the very south of the North Island, a place called Paraparaumu,
Okay.
which is just outside of. In those days, it was we'd go to Wellington. My grandmother would take me to Wellington once a year for a Chinese meal and a new pair of shoes, and it was a really big trip. But now it's just sort of like a satellite outside Wellington. And then economically, New Zealand wasn't doing too well, and my parents were economic migrants to Australia, and so that's how I got to Australia, and finished high school in Australia, and went to physio school in Australia, and then 21 years ago came to London because I wanted to see what it was like living in Europe, and got a really fabulous job in a major London teaching hospital, and loved living in Europe, and have been here ever since, but come back to Australia once or twice a year to teach and to visit my mum, who lives in Melbourne, and catch up with friends.
So are you a Kiwi? Are you an Aussie? are you a Pom? Are you a man
If
of
you
the
keep
world?
this quiet and don't tell anybody, I've got 3 passports, and what it means is I've become incredibly superficial. So whoever's winning a particular sport on the international stage, I am that country. Yeah, so I've become quite superficial, and it just depends what suits me and what visas are good. It's made traveling around the world very simple for me.
I bet that's a good way
So,
to go,
and
actually.
in the UK, I've been really privileged. I came at a time when there was huge waiting lists to see orthopedic surgeons. So the government at that stage was really, I think, quite progressive, and so was opening up the possibility for physios learning to do injections, and then physios learning to refer patients for blood tests and all sorts of imaging, and then managed to get onto a postgraduate diploma in ultrasound. So the idea was to incorporate imaging in clinics so you could offer a one-stop shop. But it also allowed me to do ultrasound-guided injections. It also the deregulated prescribing. So in 2015, I did the independent prescribing course, which allows me to prescribe medicines that are relevant for patients. Unfortunately, not allowed to prescribe Botox. So this is all real. It's L'Oreal because I'm worth it. So there are some restrictions, but it's been a really interesting evolution of the profession in this country.
Where'd you do your PhD?
I started, it was initially in Melbourne, but I moved it to Coventry University, and I had just the very, very best PhD supervisor, Anne Green, one of the nicest, most selfless people I've ever met in my entire life. And she's just retired, sadly. And that was such a wonderful experience. Such a great learning. Lonely, as you'll find with your PhD. It can be a very lonely time, but also a very inspirational time as well. And especially if the team around you is a supportive team. Now, at this point in time, you say, and you're such a supportive supervisor, Jeremy.
Could you not see my vigorous nodding? No, didn't come through.
Okay. Yeah.
Absolutely. No, you have been a tremendous help. Thank you for that. As have my other supervisors. So shout out to them. Okay. So what's a typical week looking like for you now? So I guess it's a pandemic. What's your work week? Are you sort of working university based? Are you working clinically? What are you doing?
So it's been an amazing year in some ways, a very positive year in some ways, but also incredibly sad year. I've lost family members to COVID, and had the virus myself. And my youngest daughter, who is a junior doctor, sadly had it as well. Yeah, so it's been a humbling year. It's been a year of reflection. But from a professional point of view, I work a couple of days a week as a professor of musculoskeletal research. I've got positions in a couple of universities in different countries, but all that's gone on to Zoom and emails, etc. And in the National Health Service where I work, initially it was telehealth. So you would go to, well, some people were working from home, but I just couldn't do any more work from home. So I go to the community hospital that I work in, and just speak to people on via the telephone, or they have a system like Zoom called Blue Jeans, where you could, which is apparently more secure or something. But Zoom's great. I don't want anyone from Zoom to come and get us. And just recently, last month, we were allowed to see patients face to face again. So yesterday was my frozen shoulder clinic day, and saw patients face to face, gave a couple of injections, and most of it was normal physio rehab for frozen shoulders and advice and education. And then my reflective moment on the way home, on my bicycle on the way home, thinking, have I done any good? So
Awesome.
Yeah, so it's a mixture of, it's a lot of, like everybody, I guess, like you for sure as well. A lot of it is learning to adapt to this new normal.
Yeah. I mean, I think it's we've been less affected down under, but although we have had a few issues in Victoria, sadly, and then also we've got a bit of an outbreak in South Australia. But anyway, we're all on high alert.
I saw that yesterday in the news at South Australia, and I know my mum, she's quite elderly now, and I mean, this has been a hard year for her. She's spent most of this year talking to magpies in her garden, and and so it's been a hard year. But now I think for what she's saying, she's been out in the last week or so. She's finally gone to a nursery, and and then starting to enjoy life again. But you sort of think that island nations should be doing well. I mean, New Zealand's done extremely well. Australia relatively has done very well. UK island nation, but not so well.
Yeah, we won't venture into that political conversation, but it's
after a couple of vodkas we should.
Yeah, that's offline.
Okay.
So okay, we'll leave the heavier topics, and we're going to get into an interesting. I have a question for you. It's State of Origin night here in Australia. It's Queensland versus New South Wales.
Come on, New South Wales.
Okay, well, all right. Being a passionate Queenslander, I'm gonna send you an email at midnight tonight when we win, because it's game 3 and it's one game all. So this is the decider, and we're gonna do it.
I wish I had my New South Wales.
You are in blue, so that's ominous. Anyway, okay, we're gonna get into frozen shoulder, Jeremy. Now I'm gonna start with a quote from the famous Ernest Codman. Frozen shoulder is difficult to treat, difficult to define, and difficult to explain. And he uttered those words in 1934. We are in 2020 right now. Are we any better? Are we any better off? Do we understand it at a deeper level? What are your thoughts?
No, probably not a whole lot better. But I love medical history, and I don't know if you've had a chance to actually read his book. You can read it online. The Shoulder Doc website, I believe, has got it all available online, which is a fantastic resource that they've provided for people, and I thank them for that. And it's really interesting when you read his book, isn't it? You know, that he based a lot of what he's saying on the assessment of 4 people in 1933, where he hospitalized them, tied them into elevation for 20 hours plus a day, which must have been absolute torture. They were allowed up an hour a day or so to do the famous Codman pendular exercises, and surprisingly, after a week or 2 weeks, they said, don't need any more treatment, I'm going home, things are great. And and then you get this comments that, and everyone gets better based on 4 people. and the history of frozen shoulder was punctuated by small observational studies where too much has been generated, too much unquestioned thought has been generated from those small observations. And it's an interesting history how, if you look at Codman's four participants in 33, and then, we have the Nevesia study in the 1940s that observed 10 people and said, no, it's not a frozen shoulder, it's an adhesive capsulitis. And those two, the two description of the two conditions isn't the same. A frozen shoulder isn't an adhesive capsulitis. Somewhere in the 1960s and 70s, they seem to merge somehow and they've become a synonym for each other, but they were absolutely not the same condition for most of the last century. And that was based on 10 people. So who knows what's really going on? I certainly don't know what's going on. I'd be wary of anybody who knows.
Yeah. So what do you, how do you define a frozen shoulder? If somebody asks you in clinic, Jeremy, why is my shoulder so sore? Can you give me, what's your TED talk or what's your 2-sentence spiel on frozen shoulder to describe it in lay terms to a patient?
Okay, that's a really good. I like that question. So for me, after I often when a patient's yesterday, someone's come in the room in the clinic seeking care for this incredibly painful shoulder that's way out of proportion to anything that could have precipitated it. And you ask the question in the interview stage, what's it like living with this? And 5 times out of 10, that's the time you've got to pass the patient in a physically distanced manner, the tissues, because they just break into tears that no one understands. Work for the first few days, people were very kind and understanding, but then I started getting comments like, but you haven't had a fracture, you haven't had surgery, and no one at home understands that it's agony for me to get dressed. Everything has to be done slowly. Attending to personal hygiene is, like running a marathon now. And so, once you've been through the interview stage and set the scene for the patient, we've got an hour together or whatever it is, I'd like to talk to you about, how this started and how it's been affecting you. And then with your permission, like to assess your shoulder. Once we've done the assessment, with your permission to sit down and talk to you about what I think's going on and the different management options. And together we can decide how best to move forwards. So at the end of all that, I don't really have a test to say you have got frozen shoulder. But for me, the clinical cluster has to be the person is around 50 years of age, that physiological movements are actively and passively equally restricted. One of those physiological movements has to be external rotation. And if you want to discuss that later on, we can. And that the external rotation has to be limited actively and passively at least 50% or more in comparison to the other side. And more or less the X-ray is normal. If I'm going to do an intervention, I need an X-ray because I'm a clinical coward. And so I'd say to the individual, try, validate all their pain and the difficulty. It's really important not to do that with people, and say it's most likely you've got a frozen shoulder. And then in my head, I don't like to stop just at that umbrella term frozen shoulder. You've clearly got the patient is sitting within the umbrella of a stiff and painful shoulder. And then there's so many stiff and painful shoulders, and you've got to be a clinical detective to try and work out what it's likely to be. And often it's imaging with stiff shoulders that helps differentiate the frozen shoulder to the arthritic shoulder, to the osteonecrotic shoulder, to the poor individual who's got an osteosarcoma, to the lock dislocation shoulder. There's so many reasons to have a stiff shoulder that sort of looks similar in many ways. So for me, imaging is quite important, especially if I'm going to do an intervention. So I'd say to the patient, I guess my line is, it is like you've clearly got a stiff and painful shoulder. And it is like there's many different reasons for that. And what's likely is you've got a frozen shoulder, and here are the different management options that we could discuss and consider and work out what's the right way for you to move forwards.
Cool. So certainly validate their experience, do some physical examination testing. You're looking at external rotation, obviously either in neutral or through range, I imagine. I've been having some interesting ones lately where I see people come in with not pretty good. They're okay in neutral external rotation, and then up at 90 degrees have 0 or sometimes negative, which is fascinating. So I see them coming to me, and I'm sure you've seen this, for a second and a third opinion. And they've been diagnosed with bursitis based on an ultrasound scan.
Yeah.
It's a raging frozen shoulder. Nobody's just thought to test it up through range of motion, because they're probably using their thoracic spine or something else to do the external rotation. Do you see much of that stuff, like false positives or false negatives, in your clinical practice?
Yeah, I do. I don't know what's going on here. It's such a lovely sunny morning in London, and I seem to be thrust into darkness. I don't know what's going on. Anyway, yeah. So I totally agree with that. I think when people want to try and stay as normal as possible, they do exactly what you couldn't have described it better. They're twisting on their hip to give the impression that the movement's the same. And I published a paper in 2006 with Rachel Valentine, and we had a look at some ways of measuring physiological movement of the shoulder, looking at some reliability. It was an earlier study, and we came up with a suggestion to run a tape measure from your belly button to your ulnar styloid process. So keep your arms loosely by your side, externally rotate, and it doesn't matter how much tricking you're doing. It's a linear measurement. So the way that I would use it for quickly clinically is simply to say, okay, on the stiff side, it's 20 centimeters. On the other side, it's 40 centimeters. 20 on 40, over 40 is a 50% reduction. So it's a super fast way to get because goniometry and visual is really difficult for me. And so it doesn't matter how much tricking you're doing, you can't trick the tape measure. But I totally agree with you that, when you come up into higher range, and you can do exactly the same thing, it's probably more revealing. But a lot of patients in the early stage, you can't get them up into higher ranges.
Absolutely.
Without the embarrassment of screaming coming out of your clinic.
Yeah, it is and I'm glad you touched on the emotional aspect or the mental load of frozen shoulder, because it's a condition. I'm probably with a really acute sciatica, it might be similar, but a frozen shoulder. I've been reading a little bit of some qualitative research around frozen shoulder, and there's not much out there, sadly and embarrassingly.
There's a Jones study from 2012, yeah. And keep an eye out for Will King. He's doing some stuff in down the south of England, and also Chris Billsborough, who's doing a PhD injection study that I'm supervising for frozen shoulders, and she's just putting the finishing touches to what will be a qualitative piece to her PhD as well. So I agree with you. There's not enough qualitative patient perspective information. I'm sure every day in your clinic, you have the patient who's crying and desperately trying to understand what's going on, and desperately confused that everybody is saying something different, and looking on Google, and Google saying the best treatment is organic ginger picked at 6 o'clock in the morning on the west side of a mountain by people pure of heart, so there's so much unsubstantiated stuff, and I don't think we've got enough about the patient's voice in this, and I'm sure that's your experience as well.
Absolutely. It's the Jones study that you mentioned is fascinating, in that people just want to know what's going on, so they want an accurate diagnosis. Who would have thought, right? That goes back to Louis Gifford's 4 principles of what patients want when they present to you, and often they're just going around from GP to physio to chiro to osteo or whatever, and they've all been telling different things. It's your alignment, it's your posture, it's your bursa, it's the rotator cuff tear, it's this, it's that. It flummoxes me as to why frozen shoulder is such a hard diagnosis for some clinicians to make. It should be the most obvious presentation that you can see, surely. What's going on? Are we too entrenched in the biomedical model where we're looking at macroscopic structure on ultrasound, or we're looking at the tightness of trigger points of tissue, and we just lose sight of an obvious clinical presentation? Why do you think we miss, or it is common to miss, a diagnosis of frozen shoulder?
I love the way you reflect and you think. You thought carefully a lot, and I really admire that. So thank you. Yeah, thank you. I like the way you're pitching this. I don't know. I mean, I make lots of mistakes. Someone comes in with a terribly painful shoulder, and my first thought is this more likely a, without the benefit of imaging, is this a calcific tendinopathy? The patient's rubbing up and down their upper arm. Is this a nerve root compression? Is this someone who really has pushed themselves beyond their absolute physical limit and really does have some evidence of bursal shoulder pain, which there is some evidence that can happen? Or is this just the person's interpretation of what pain is inside their body, and at the same time that they're desperately financially struggling because of the pandemic and their children are not being educated? So so it's sometimes really complex to say, and I make mistakes, and I'm not ever critical of anybody saying, oh, this is a rotator cuff, or I would be critical if they said this is an impingement, but you see, you think this is coffee. Anyway, so so sometimes it takes a while to declare itself. But I agree with you that everything's a hypothesis in our world. Rotator cuff related shoulder pain is a hypothesis. It's likely to be that based on these sets of circumstances from the interview, from the clinical examination, and that hypothesis may change over time. So, so for me, the hypothesis of frozen shoulder is the factors I mentioned earlier up: 50 active passive ranges, restricted. One of them has to be external rotation and a normal image. But then why the shoulder is a frozen shoulder is another huge question in itself. What category of frozen shoulder are they? I don't think we can just stop at this is a frozen shoulder and it's without any shadow of a doubt your capsule that's contracted. But the overarching theme is, this is, if you want to come up with a different term, that's fine. But for today, it's called a frozen shoulder, and based on those features. So it might take some time, but I think you can get there.
For me, frozen shoulder, whenever I refer to frozen shoulder, I'm going to refer to, for this question anyway, a true idiopathic capsular contracture. Somehow we've observed, let's just say that we've done a biopsy or we've gone in there for an arthroscopy or whatever. That frozen shoulder is almost the most definitive observation that you can make, I think, clinically in physiotherapy. If you took 100 people and contracted their capsule, they're all going to move within 10 or 20% of each other, I think, in terms of they're going to come in and they're going to have those cardinal signs of how they move their shoulder. So this is where I think it's slightly different from a rotator cuff related shoulder pain presentation, where it could be any number of structures. That's talking about nociception. It could be any number of psychosocial factors or physiological factors. We'll never truly know, I don't think. It's just pain in the shoulder. But a frozen shoulder has a very clear pathophysiological profile in many cases, and I certainly know that there are some that do not follow that we'll talk about in a moment with the pseudo frozen shoulder, with the work from Louise Hellman. But do you agree that a true sort of capsular type presentation of a frozen shoulder is a pretty definite, once it reveals itself, once it declares itself after those first few months,
Mhm.
should be an obvious clinical diagnosis.
Yeah, and I agree with that, with the um, with the proviso that how so I totally agree with everything you just said. How are we determining that the capsule is contracted? So that's my question back to you. How would you? So if
Absolutely,
you
yeah.
don't have the advantage of an arthroscope or histology, biopsy, how are we making that call? I mean, yes, we can see on MRI, we can see on ultrasound, we can see some possible structural changes. Maybe that takes us to that point. I've certainly been speaking to some interesting. There was a radiologist I've just been speaking to who's convinced now that for those of people who are familiar with scanning the shoulder, when you put an ultrasound machine on the shoulder, you can clearly see the rotator cuff moving and the deltoid not moving at all when you do the scan. And this gentleman's been sending me some anecdotal imaging ultrasound videos where in patients with frozen shoulder, he's observed that the rotator cuff and deltoid are almost like glued together and moving together. And he's interested to research that sign. And I don't know enough about it. I certainly spent yesterday in the clinic with the scanner trying to see if I could see it, and I couldn't. But I don't know if that could be my poor scanning technique.
Yeah, yeah.
But you know, so I totally agree with you. But we can only do that once we've got the definitive evidence of coracohumeral ligament or some part of the capsule has contracted.
Mm.
And then I agree, it should be the best, most simple, clearest diagnosis in the history of diagnosis.
So absolutely, that's the thing that, yeah, the determination of whether the capsule is involved or not is a huge missing piece, and this sort of leads us into Louise's work that we've just mentioned, and her now pretty famous paper, and quite rightly so, which came out a couple of years ago, which put 5 people, I believe, under anesthesia, general anesthesia, and measured their range of motion versus when they were awake and they were diagnosed with a frozen shoulder. And as you know, substantial improvements under anesthesia, and the assertion or the question is, do people with a frozen shoulder, or a subset of people with frozen shoulder, have an active restriction or a muscle guarding? Can you speak to this? Do you have a theory around these potential patients or subgroup of patients? Do you see them in your practice? Do you think they're out there? And if you do you treat them any differently?
Great question. I mean, yeah, hat off to Louise and hat off to Karen Ginn. I mean, you know, enormous contribution, Karen Ginn and her PhD and MSc students, and Louise's study was so profound and so interesting. And yes, it's small, but it needs to be considered, and we need to explore it further. And we're certainly doing some research in Illinois, in the States at the moment, furthering Louise's research with a couple of colleagues internationally. And so I don't know how to work out the muscle guarding component. If we go back to your earlier sentence about the true capsular contraction, if we look at the research that's available to us, it's suggesting that physios can mobilize inferiorly the glenohumeral joint with around about 20 kilograms of, I don't know, 20. So if you're pushing on a bathroom scale or you're doing a JMAR thing, it's about 20 kilograms, the force we're applying. Is kilograms of force? No, I've got that wrong. But you know what I mean. So let's even put our whole body weight behind it. Let's say we're mobilizing the inferior capsule at 100 kilograms. It seems to be that the force required from Professor Ito's work from Japan we need about 683 kilograms of force to stretch the inferior capsule. From my knowledge, the heaviest deadlift last year was 500 kilograms. So the good news is that the heaviest deadlift is still not this. You know this better than I am. I think you're a lifter, aren't you? You're a weightlifter.
Yeah.
And
can't you tell that's 600 kilograms of force right there, man?
How's your subscapularis, by the way? Anyway, so what was that whole region? Anyway, so I'm far away now. You can't come and punch me anyway.
Yeah, exactly.
Anyway, so the good news is that the heaviest deadlift is still not strong enough to stretch the posterior capsule, because if it was, we'd be in a lot of trouble trying to lift a heavy weight.
Mm-hmm.
So it would be naive for physios and chiropractors and osteopaths to say, I'm stretching out your inferior capsule with this mobilization procedure. And there certainly is evidence that mobilization has some part to play. That was in a paper we published last year, our systematic review that Catherine Winslow led on. But it can't be that we're stretching the capsule. Not even someone as immensely strong as you. And so are we really, maybe what we're doing is we're decreasing the muscle guarding. And that's where we're seeing the benefit from exercises and stretching and mobilization procedures. So maybe that's when it does change. Maybe that's suggestive that part of the problem is muscle guarding. A colleague and a friend of mine, Owen O'Connor, back in 2010, we were the first physios. We put in a grant to a brilliant funding source called the Health Foundation in the UK. And the Health Foundation gave us a lot of money to set up a hydrodistension clinic run by physios, totally just physios, in community care. And we were the first to do that. And we had some amazing help. Alison Hall, teaching us, a sonographer, teaching us how to do the procedures. We put a lot of effort into learning how to do hydrodistension for frozen shoulders, because we really wanted to offer a one-stop shop. And we try to keep it as accurate as possible. So if I did the injection, Owen would reassess the patients, and if he did an injection, I'd reassess, so that we were not trying to bias our own findings. And what we could never understand is that sometimes you've got an ultrasound machine, the needle's in, you're putting in 30 mils of saline, so you're not up against the bone. And sometimes the injection would go so smoothly, and you see this expansion of the humeral head and the glenoid fossa. And sometimes your arm would end up looking like the Hulk, because you just could not get any saline out of the needle, out of the syringe. And we just couldn't understand it. We talked a lot about it. And I wonder, because if you sort of think about it, if it does require 680 kilograms of force to stretch the capsule, what could 30 mils of saline do against that? You couldn't. I don't think I could generate enough force. I don't know. And when it's easy, maybe what we were seeing were muscle guarding as the reason for the clinical presentation of the frozen shoulder. I don't do hydrodistensions anymore. I've stopped doing that for many years now. But I know a lot of people do it, and a lot of people talk about the success of doing it. But this we're going to leave this conversation knowing less than we started at the beginning of it. It's such a hugely interesting topic that we know so little. I know so little about. That we're trying to learn about it, but it's complex.
Yeah, no, I'm with you. So, okay, I think this sort of leads quite nicely into an injection question. So I think the three obvious candidates would be just a low volume intra-articular injection. You've got your high volume, and then even the old subacromial injection, which is still done and which doesn't make logical sense to me, but the data suggests it's not heaps worse than an intra-articular injection, as far as I can see. At the end anyway, maybe it lags behind initially. So it seems like you've retired your hydrodilatation or hydrodistension injection, which is interesting. They're becoming more and more popular here down under. And I know they're very common in the UK. I worked over in London for a couple of years, and lots of the consultants love to do a hydro distension procedure. What's your experience? Or firstly, what's the rationale behind an injection from a pathophysiological perspective? And then how do you find they go anecdotally, of course, and you can make reference to the literature if you like?
Okay. Well, this is a PhD, this question. It's a fabulous question. How much time do we have?
10 minutes to go, Jeremy.
Okay, cool. I'll get it done in 2. So this is just a conversation between me and you. No one else is going to hear this. That's right.
Nobody else except
Okay,
thousands of people.
So we know that lidocaine and steroid can reduce fibroblast populations. Vicky Ryan and Hazel Brown, for their masters that I contributed to, did a really interesting systematic review in 2016 in BMC MSK, open access if anyone wants to read it, trying to look at the pathophysiology, the histology of frozen shoulders. And what was really interesting, we could not find one naive study, meaning that we couldn't find any study that had the tissues that when they were being sampled had no intervention, no injection, no physio. So we don't know what's really going on at a pathological level in a naive frozen shoulder. And so we made our cutoff. I think the only thing the participants could have had was non-steroidals, which still has a chance to influence tissue. One of the things that they reported was that in the coracohumeral ligament and in parts of the inferior capsule, my memory serves me well, that there are fibroblasts in those areas of the capsule, and they are myofibroblasts. The myofibroblasts can cause contraction, and maybe that's where the contraction that you were talking about before comes from. Now, if injections if that combination of lidocaine and or steroid can reduce myofibroblast populations in other studies, I wonder if one of the reasons why injections work is that it is reducing myofibroblast populations, and it is then stopping the progression of the contraction, because the injections, from my clinical experience, but also the paper we published, the systematic review we published last year in Journal of Rehabilitation Medicine, suggested that injections work best in the painful stage. They don't seem to work in the stiff phase, and the earlier the better. So I wonder, so of course it could be having an effect on inflammation, which we still don't really understand. The injections might be diluting chemicals in the joint. It could be contextual if it's muscle guarding. Who knows anything really? But at a physiological level, which I'm really interested in, is it possible that if it is a true frozen shoulder and there are myofibroblasts causing the contraction, and this medicine can reduce the number of fibroblasts, is it restoring homeostasis in the region? Why that? I don't know. This is, I'm sure I'll be shot down by someone, but I'm saying it before the end of this. I don't know its hypothesis, so it'll be interesting to explore. What I see clinically and what I do clinically now is, as long as the patient understands the risk, because there are risks of the injection, it's not that it's a risk-free procedure. And as long as they consent to all the things I want them to do afterwards, I actually do 2 injections on the same day. I'll do an injection inside the joint, and I'll do an injection in the bursa. And it was interesting, in 1850s, Duplay, the first person to really talk about frozen shoulders, was suggesting that the cause of the frozen shoulder was bursal stickiness. So he had an adhesive theory as well, but it was the bursa, subacromial bursa, sticking together, and that was causing the pain because you just couldn't move, and it was causing restricted movement. And it does, and I agree with you, there's not a huge difference where you do the injection. So is it contextual? Who knows what's going on? But I think the evidence suggests that an intra-articular injection slightly wins that competition. A bursal injection by itself slightly loses that competition. But when you add the bursal injection to the glenohumeral injection, it seems to improve hand behind back range more than just the intra-articular injection. Now, why that's the case, I don't know. We're currently setting up an RCT to look at that. But, you know, what the bursa contribution is, I don't know. Maybe it's turning off pain a bit. I don't know.
Oh, that's a fascinating hypothesis in regards to lidocaine and steroid inhibiting or reducing fibroblasts or myofibroblasts. That completely sort of goes in the face of a hydrodilation injection trying to distend these mechanical things that we're obsessed with in physio, right? But perhaps something is going on at a deeper physiological and certainly psychological level. I know from my experience, if I have someone who has had a hydrodilation injection, and it makes sense, it's coherent to them. If they go and have an injection and it's going to blow up their capsule, it's going to dilate their capsule. And I'm sure there is some contextual effects to having a hydrodilation injection. And plus they hurt a bit as well. So I think they can, and sometimes they pop and they hear a rupture, or they can hear that popping sound. And so they come in, and those people who say it, they're like, oh, it's so much freer now. And the radiologist said it's great, it popped. So that's that's an interesting, actually, let me ask you that. Do you think a hydrodilation injection can rupture a capsule? Can given what we know about the force that's needed to do it? That was the theory, that a hydrodilation would cause a rupture of the capsule. Is it plausible?
I guess it's plausible. I guess if it takes 683, kilograms of force per centimeter squared to stretch the capsule, hard. I can't imagine if you had an injection. What's half a Volkswagen Golf. I don't know if that weighs 600 kilograms, but whatever. If you couldn't imagine putting 30 mils of fluid behind a Volkswagen Polo. I'm not trying to advertise Volkswagen. This was brought to you by every car manufacturer. I can't imagine 30 mils of fluid could actually move that car.
Yeah.
I can't imagine it. A little bit of, but maybe in a confined area it can. Certainly had situations where I have seen the fluid go in, a noise happened, and then the fluid dissipated. So I assume something has ruptured. I don't really, not 100% sure what. But my question was, and Owen and I had this conversation, is it acceptable to cause a rupture and then let steroid flow, who knows where? Are we causing any problems? Because the way some people do the injection is it's lidocaine and saline. Some people do the injection lidocaine first and saline. Some people mix saline, lidocaine, and steroid. And is it acceptable to have these things free flowing somewhere? Does that cause any iatrogenic problems? And I couldn't find an answer to that. So there was a whole lot of reasons why I decided that it didn't make sense for me to do hydrodistension. I'm sure a lot of people who are listening to this or not listening to this who do hydrodistensions have very valid, sound reasons for doing it, but I'm not convinced by the research on hydrodistension. It certainly wasn't included in our recent paper. It's certainly not included in the UK Frost trial. So I'm not sure we've got definitive evidence for distensions. And yeah, I don't know if that answers the question, but that's as good as I can get, I think.
It's good. So I think I'll ask one more question, and you just reminded me of the Frost trial. I don't know if you've had a chance to read it. Interesting result. So three group RCT, physio, standardized physio. It was after an injection, I believe, to start with, versus a manipulation under anesthetic versus a arthroscopic capsular release.
Yeah.
Seems to be no superiority of one over the other after 12 months. I believe there were some so physio needed more treatment. I think manipulation under anesthetic perhaps the most cost effective, which was a fascinating
Yeah,
outcome
it
to me.
completely blew me when I read that. I thought,
Yeah.
well, that's really challenged everything. Every surgeon I've ever attended a lecture on talking about it says manipulation under anesthetic, really rough, damage the shoulder, rip the labrum, cause fractures, cause hemarthrosis, much more sophisticated, much more finesse to do a capture release. So I've sort of been towing the party line when patients are saying, listen, what you're doing is not helping. What else can we discuss? So I've been saying for a long time, oh, capture release is the way to go, because it had become part of my DNA, basically listening to, surgeons' experiences. And so the Frost trial really has challenged that, and rightly so. To say huge credit to the researchers and the participants who contributed to that knowledge. I guess for me, it sort of still does reinforce do the injections and do physio after the injections. And then if it's not declaring itself and the individual is looking for some other way forward, and understands the risks and benefits, go and do a manipulation under anesthetic. I presume that should be the care pathway now. Conversation that's been happening, as you're aware of on social media, is should have there been a fourth group, the advice, education, and wait and watch, which would have been really valuable. I'm not for a minute criticizing the Frost study, but at some stage in the future, it'd be really valuable to have that comparative arm as well, because maybe it's just time. It doesn't really matter what you throw at the patient.
Yeah, absolutely agree. I think it's an interesting outcome, because I've been practicing for about 10 years, and I don't think I've seen a frozen shoulder after a manipulation under anesthetic in the past decade. I've sort of sat in and watched a few arthroscopic releases as I work with some surgeons here, and they do well post-operatively, to be honest. But yeah, it must inform practice, and in a manipulation under anesthetic. I don't know how much we should extrapolate. I didn't go in and have a look at the patients who did it anyway. I don't know if we can just extrapolate it across the board to every country, to every patient demographic, but it's interesting nonetheless. We should be thinking about a manipulation under anesthetic, which for me seems like a barbaric procedure, as you alluded to. It seems like it's contrary to sort of everything that I believed in. So it's really got to make me look at my own clinical practice as well. It's interesting.
I guess that's the value of research and acquisition of knowledge, not being stuck in one place and testing hypotheses, trying. And what are we all trying to do? We're all trying to make the lives of people coming in seeking care as better as possible. And I know there's huge debates, especially in social media, about how dare you do this and why would you do that? But the truth is, we're all just trying to, make our little corners of the world the best possible and try to help people as much as we can. And, certainly my experience of the privilege of teaching around the world has been that physios are really nice people. They're really trying to make a difference and trying to learn and trying to work out what works. And yeah, so I guess what we're all trying to do is just add to our knowledge and add to our ability to help people. I'm certainly a different person today than when I finished minute therapy in Melbourne, And
yeah, that reminds me of a quote, another quote from Karl Popper, who I've been reading his book recently, and he's like, all knowledge is temporary, provisional, and capable of being refuted at any point. So don't hold your beliefs too tightly or too closely. And that rings home with that Frost trial as well. We've got to be adaptable and go where the evidence takes us. And, there's not enough of that, I don't think. Seems like, I don't know, maybe we're just in these silos, but we're just getting more polarized by the day, both in physio and politically all around the world as well.
And you mentioned Louis Gifford before, and I remember, just finish on this because we've got to all sit down and pray for New South Wales to win tonight. As the screen goes blank, I'm not really invested either way. I did a 5-day course with Louis Gifford and David Butler. I was a student in a 5-day course, and it was at the beginning of, it was in Abergavenny in Wales, and I flew across to participate in it. I really wanted to participate in it. It was an amazing course, and it was sort of the time where they were really challenging mechanical ideas and talking more about pain. And I didn't even realize it was a brain before I did this course, and know that thing existed. And and Louis was just so eloquent and clever and a philosopher and knowledgeable. And he was talking about pain the whole time, and how we have to reframe, reconceptualize. And then the last day, or the last 2 days, they had patients, and this first patient came in, and this is after 4 days of just solidly no hands-on, think about different ways of working with patients. It was revolutionary. And the first patient came in, so I got a really sore neck, and what's happened? And Louis asked him, what's been beneficial in the past? And he said, oh, I've had these manipulations, and it's always helped me for years. So without any thought, Louis put him in supine, manipulated his neck, and the guy said, thank you. And we were looking at each other, and then when we were sort of saying, why, Louis? we've just learned about the brain, and there's this thing called pain that no one ever heard of before. And he said, because that's in terms of conceptualization, why would I have done anything else for this patient? Yeah. And it was really, really interesting and insightful and really mature, I thought, that he was listening to patients and not just listening to ourselves as health professionals. It was really, yeah. Anyway.
Being intellectually humble and not putting your own biases onto your patients is such a golden rule. So thank you for sharing that story. That's amazing. That's a good place to finish. Thank you, Jeremy, for joining me for the past hour or so. You've got so much knowledge, mate, and I really appreciate you taking the time early over there in London to speak to me and to everyone who watches this. So thank you very much.
Thank you very much for the invitation, and come on, Queensland.
Cheers, mate.